Ms. B is a 50-year-old woman with well-controlled HIV who presents with day and night sweats. So how should symptoms like these be evaluated? The first step is a focused history. Over the past 6 months, her symptoms have reflected menopausal hot flashes, sudden onset of heat in the chest and neck, flushing, sweating, and nighttime awakenings that disrupt sleep. Assessing menstrual history also matters. She reports that her periods have become irregular over the past 6 months, and her last menstrual period was about 3 months ago, an important clue related to the menopause transition. But clinicians should also ask about other symptoms that could explain the sweats she is experiencing. She denies fever, recent illness, weight loss, heart palpitations, chronic cough, recent travel, and new medications. These negative findings make several alternative diagnoses less likely, including an infection, systemic illness, and medication-related symptoms. Physical examination provides additional clues. She is well appearing with normal vital signs and no lymphadenopathy. Pelvic examination shows vaginal mucosal atrophy. Vaginal atrophy is often seen during menopause. Her HIV history is also reviewed. She remains adherent to antiretroviral therapy, with a stable CD4 count and an undetectable HIV viral load. That makes uncontrolled HIV less likely as the cause of her symptoms. At this point, targeted laboratory testing can help rule out other potential causes for her menstrual irregularity and symptoms and support the diagnosis. The clinician orders a complete blood count, thyroid-stimulating hormone, prolactin, follicle-stimulating hormone, estradiol, a pregnancy test, and HIV-related lab tests. Each test answers a diagnostic question. CBC looks for clues related to systemic illness or infection. TSH helps rule out thyroid disease. Prolactin can help identify endocrine causes of menstrual change. A pregnancy test remains important when the menstrual pattern changes. A CD4 count and HIV viral load help confirm that her HIV remains well controlled. The FSH and estradiol results are not reliable if they are not collected at a distinct time during the menstrual cycle in menstruating women. In this case, the timing of specimen collection is hard because she has irregular periods. These hormone levels cannot be relied upon to determine menopause stage for this patient, though they may provide some insight if the results were grossly abnormal. In certain cases, and particularly for postmenopausal women, FSH and estradiol may be helpful with supporting menopause stage when interpreted alongside her symptoms, menstrual changes, and exam findings. The results are reassuring in several ways. Her CBC, TSH, and prolactin are normal. The pregnancy test is negative. Her CD4 count remains stable, and her viral load is undetectable. Together with her age, symptom pattern, irregular periods, and vaginal atrophy, these findings support a diagnosis of perimenopause, and her sweats are most likely menopausal hot flashes. So this is a key diagnostic point. Do not automatically attribute these symptoms to HIV, but do not assume it is menopause without a comprehensive evaluation. Use medical history, particularly a detailed history of menstrual patterns, including conditions or treatments that may influence menstrual patterns, physical exam, and targeted laboratory testing to safely rule out differential diagnoses. In this case, the final diagnosis is perimenopause with hot flashes in a woman with well-controlled HIV. Her vaginal dryness and atrophic findings also support genitourinary syndrome of menopause. Once the diagnosis is established, the next step is to consider treatment options, medication interactions, and broader midlife health needs. Watch episode 3 to learn more.